Thank you for inviting me. I love being part of this course. Once again, Mike has put together a fantastic course, and it's just very impressive, and it's a pleasure to be a part of it, so thank you. Okay, we're going to talk about the use of breast MRI in high-risk screening. I don't have any conflicts of interest or financial disclosures. We're going to look at who is at higher than average risk, and then we're going to talk about MR for those women, and we'll compare it to mammography because that's the standard for screening. And then we'll summarize the new ACR recommendations which we published this year. All right, what are the populations at higher than average risk? Well, the obvious one is those women that have a genetic predisposition, and there are a number of different, see if I can, there we go. There's a number of different genetic mutations. Some of them confer additional risk for other types of tumors, not just breast, but all of these patients will have an increased risk of breast cancer. Probably the best well-known are the BRCA mutations. They are the ones that were discovered first, and they are more common. So women with either BRCA1 or BRCA2 have a very high cumulative lifetime risk of breast cancer, and it depends on what paper you look at, but it's always over 60% higher for BRCA1s than BRCA2s. And even if they're treated for their breast cancer, they remain at higher risk than the average woman with breast cancer for a contralateral malignancy. So they have a continuing risk over lifetime. It's been well known for quite a while that women of Ashkenazi Jewish descent are more likely to have BRCA mutations, but what's less well known is that is also true for African American women. And I was surprised at this when I did the lit search for the high-risk paper because it's not really new data, but it's really not very well known. If you look at this very large study, you can see that African ancestry confers a higher risk of either a BRCA1 or a BRCA2 than women of Western European descent. In fact, black women have about a 22% chance of having a genetic mutation, and that's about double what it is for non-Hispanic white women. The disease for BRCA carriers is different, especially for BRCA1 patients. So if we look at this data from Japan, you can see that for BRCA1s compared to BRCA2s, they have much more invasive disease. In this case, none of their cases had DCIS, where DCIS is prevalent in BRCA2 patients. And you can see that triple negative disease, which is much more aggressive, breast cancer, is very predominant in patients with a BRCA1 mutation. And this data from Germany shows, compares BRCA1 and 2s to other patients that are high risk for other reasons. And again, preponderance of high-grade tumors in BRCA1s and triple-negative disease. But even for BRCA2s, they have much more triple-negative disease than other patients who are at high risk for other reasons. So more high-grade tumors, more invasive disease, and more triple-negative disease, so aggressive disease in these women, especially for the BRCA1s. Now, this is a table from our paper that was published this year. It's adapted from the NCCN's data, and you can see the different mutations and the lifetime risk, and you can see it's pretty high for all of the mutations. All right, so that's genetic mutation carriers. Strong family history also confers a risk even without a mutation, and what's important are the number of family members, their age at diagnosis, and whether or not it's a first-degree relative. So if a woman comes in and says, my mother's cousin had breast cancer, that puts the patient at higher risk. But if they say my sister had bilateral cancer at age 40, then that's a much, much higher risk, and she'll calculate higher for her own lifetime risk. So what we use are usually risk assessment tools. There's a lot of different tools that are available. Probably the most common and most comprehensive is the Tyrer-Cuzick, which now also includes breast density. But none of these tools is really fabulous. When you look at them overall, their discriminatory ability is just moderate, and that's a little bit disappointing. There is a new way to do this using deep learning. I don't know if any of you saw these papers. Very interesting. Looked at mammograms, let the computer do it, and then the deep learning model, it learns off each one. We know at the end which women had breast cancer, and the computer is seeing things we can't, and we don't know what it's seeing. It's a black box, right? That's what deep learning, those algorithms are. And they actually did better than Tyrer-Cuzick. The obvious problem with this is you have to have a mammogram, and we usually don't mammogram women under the age of 40 necessarily, so it's hard to use it for young women at the time when we should be assessing the risks in their 20s. Regardless, family history will remain important, and it's a really good flag when you're doing your intake for screening. And you'll notice here that family history is important no matter what, because look, these are BRCA carriers, but their risk goes way up if they have a number of relatives. So it increases risk even for mutation carriers. You can see the hazard ratios here. Okay, so those with a strong family history. And then next is a history of chest radiation at a young age, by which I mean more than 10 gray before the age of 30. If they've had more than 20, they're at especially high risk. The risk starts about 8 years post-treatment. And just to give you a ballpark, for a patient who has Hodgkin's and gets mantle radiation at age 25, by age 45, they're going to already calculate above 20% lifetime risk. And it's especially higher for teenagers who are treated with Hodgkin's because their breasts are more radiosensitive. All right, the next high-risk group are those with a personal history of breast cancer. That's a lot of women. And this meta-analysis shows that their recurrence rate over time and their death rate continues to be high. So we usually say for a woman who's had unilateral breast cancer, they have about a 1 to 2% per year risk of having another cancer. And for the contralateral breast, it's about 0.5% to 1% per year. So they have continuing risk over their lifetime. And basically anybody who's diagnosed prior to age 50 is going to have a calculated lifetime risk of another cancer greater than 20%. So they're going to qualify already, right, just based on that for MRI surveillance. All right, what about atypias? Atypical ductal hyperplasia, atypical lobular hyperplasia, and LCIS. LCIS is getting a new look, and I think the new BI-RADS is going to address that. But overall, ADH has about, if you can just think of it in ballpark terms, about a 5 times higher risk than average breast cancer, and LCIS about 10x. Black women. Our report in 2018, which was the first high-risk recommendation paper, called out black women as a separate risk category for the first time, and part of that is the higher incidence of genetic mutation for these women, which I've also shown you, but they also have an incidence of breast cancer that now equals non-Hispanic whites. It used to be less, but in spite of that, they have a 40% higher mortality rate, and they have a 2-fold higher rate of triple-negative disease. They get cancers at younger ages, and they die more commonly at younger ages than white women. So this is a very high-risk group. And then finally, women with dense breasts. So you're all radiologists. You know that dense tissue is white, fat tissue is fatty tissue is black. And if we compare the extremely dense women, which is on the 10% of the bell curve on that end, to the entirely fatty, if we look at those and compare the extremes, it's about 4 to 5 times increased risk. But you know, that's not how we normally discuss risk. We normally look at risk compared to the average woman, and neither of these is average women. So that is a little bit misleading, I think. The average woman falls somewhere in here. So if we compare the dense women to the average, the risk is about 1.5x. All right, so it's not insignificant, it's just a different way of looking at it. So that's the populations that we have that are at higher than average risk. Okay, so what about MR and mammography in these women? So MR is more sensitive than either mammography or ultrasound in high-risk women. Really true in all women, but this is the early data. Krieg's report was first, and you can see how much higher the sensitivity MR is than conventional image in any study. And this is important because it shows this consistency over different types of studies over time. And this is more recent data, and I've included the populations here that we're considering, and you can see again that basically MR knocks the pants off conventional imaging, so it is the way to evaluate high-risk women, and it is the way to screen them. Now, in addition to being more sensitive than conventional imaging, MR detects tumors when they're smaller. It's very good for DCIS now, lower node positivity rates, and key in this is that there are lower interval cancer rates when we screen with MRI. Here's a randomized trial done in the Netherlands, 12 hospitals, and you can see it's young patients, and these were not mutation carriers. These are just women with a calculated lifetime risk. It was kind of interesting the way they did this study. The MR group had annual MR and biennial mammograms. The mammo group had annual mammograms, so it's kind of a little bit apples to oranges comparison. Both groups had clinical exam. And here's what they found. The MR group had more cancers detected at a smaller size with less node positivity. That's a pretty significant difference in each case. And even into the incident rounds, you know, the prevalence rounds you always find more, but what happens over time? And with incident rounds, you can see that the MR group maintained better lower stage presentation than the mammo group, and the node positivity remained much smaller than the mammography group. And this is again compared with annual mammograms in high-risk women. So the MR group had smaller cancers, less node positive tumors at earlier stage, and lower numbers of late-stage cancers, which directly correlates to mortality benefit. And this is the first randomized trial to show a stage shift for MRI in high-risk women. So our newest recommendation, which we just published this year, we recommend again annual MR for these groups, and nobody's going to be surprised at that because we've been saying that forever, and so is the ACS. What's new in this recommendation we just published earlier this year is for mutation carriers and their untested first-degree relatives, start MR 25 to 30 as before, but they can wait until 40 for mammography. And we were kind of pushed to do that with the 2018 paper. There just wasn't enough data, and now we're moving toward that. That assumes that you have yearly MRI screening, though, from a young age. Now, this is the 2018 paper. We looked at mostly the BRCA carriers, and there was some discussion at the time, mostly for BRCA1s because they're more radiosensitive, that maybe they could skip mammography. But we decided the decision to exclude mammography for BRCA1s under the age of 40 was not clear. Why is that? Well, many of the studies were small, retrospective. There was really no tomo. It didn't reflect the kind of mammography we were doing now. But this is what informed our 2018 recommendations. And this is a typical paper. So if you look at BRCA1 and 2, all ages, here's mammo, MR, here's the combo, and this is the added sensitivity of doing mammo with MRI. You can see it's small, about 4% for BRCA1s, higher for BRCA2s, but for women under 40, the numbers are pretty high, especially for the BRCA2s. So this is what informed the 2018. We said, look, you know, BRCA carriers often will take every benefit they can get, so even if it's small, at 4%, it's probably worth it. So we didn't feel comfortable telling them, forget about it, or wait till 40. Now, this is new since we published in 2018. This was reported in 2019, and it was very influential, this Ontario breast screening. You can see the high-risk groups they included, all different types, mostly family history. I looked pretty carefully at the methods in this paper, though, and the mutation carriers are almost all BRCA1 and BRCA2. Not completely, but you can see it's a high percentage of BRCA1s and BRCA2s, and that will be important later, which is why I mention it. So here's what they found, that the sensitivity for mammo is low, MR is high, and the two together is highest. And, you know, you have it for the younger women, you have about a 3 to 4% increase in sensitivity by adding MR. Less so for the older carriers. And so what these folks did is they looked at specificity, and they're doing this balancing act again. They're trying to decrease false positives. And they said, well, for younger women, the specificity change is, you know, it's more favorable to just do MR. It turns out they didn't report the specificity p-values, but I looked at the data, and it's really the same for the older women. So, it's a good paper. I'm not saying that it's not, but these authors are again balancing sensitivity and specificity like the task force does in their guidelines. And we disagree with that at the ACR. We think this decision should be made by women, not for women. So I'd rather tell the women, here's the benefit, here's the risk, the downside, you pick, rather than saying, well, we're going to look at the balance and tell you what to do. But that's what they did in this paper. They basically said MR gives the best sensitivity trade-off with specificity, and it's more important for younger women. And then they basically said over 50 you should do both. They didn't say anything about the women in their 40s. The next paper I'm going to discuss also came out just last year, 2022. CISNET modelers looked at modeling analysis for ATM check and PALB2 mutations. These are all higher lifetime risk than 20%. So we're going to be looking at them for surveillance. And it's interesting what they did. So first of all, they looked at annual mammogram and then compared what happens when you add MR at 35 and then 30, and you can see the benefit goes up. Of course, they're again only modeling to 74 because apparently women over the age of 74 aren't worth thinking about. And that's always bothered me because we do have the data for women past 74, but they don't include it in the modeling. But you can see you can get close to a 60% mortality reduction in these women by using MRI starting at age 30. So then they turned that around and said, okay, we're going to accept MR at 30 for these women. What if we do mammogram earlier at 35 or at 30? And you can see there's only a small incremental benefit. And they use this to say, well, you really just need to do MR and you can wait till 40 to do mammography. And we ended up saying that in our recommendations. But I want to point out that this is a modeling study and they heavily weighed the Ontario paper I just showed you in their modeling. There's just not that many studies of this. And I already showed you how few mutation carriers they had that were not BRCA1 or BRCA2. So you have to be a little bit cautious. So even though we looked at the preponderance of evidence and said, okay, we can tell women if you're doing regular MR, you probably don't need a mammogram till 40, I certainly wouldn't argue with anyone who wanted a mammogram at 40. Because we have also information like this, also came out since 2018. This is looking at interval cancers in BRCA patients. And the patients that have interval cancers tend to be younger, Black women, they're all invasive, and they're larger and higher stage. So the interval cancers are bigger than the screen-detected cancers. They're more often node positive. But what they found is women screened with both ammo and MR had a lower proportion of interval cancers, which really kill women, compared to women screened either only with mammo or only with MR. So again, there is not universal a feeling that mammography will not help these women. So here's what we said in our 2023. As you can see, we just published it in JACR. The use of mammography is controversial, but for mutation carriers, they can probably safely wait till age 40 to have mammography, but they need to have annual MR starting at age 25 to 30. Calculated lifetime risk greater than 20% start at 30, and then chest radiation patients should start at 25 or 8 years after treatment, whichever is later. All right, let's look at some of the other categories. The one we have the most data on is personal history of breast cancer. Long shown that the cancer detection rate is very high with MR in these women, much higher than conventional imaging. This particular paper by Chow used abbreviated MR, and even with that, 15 cancers per 1,000, and the majority were not visible on conventional imaging without any interval cancers. So this is very strong evidence that MR is useful in women with a personal history. I've listed some other data here. Basically, it performs as well as it does in women with genetic mutations, especially in young women and those with dense breasts. Here's an example of women 50 years or younger at diagnosis, and you can see adding MR increases the sensitivity by double, and the cancer detection rate is doubled. Again, no interval cancers. So very powerful in this population. SIPO's study did something interesting. It compared those with a family history, personal history, and even high-risk lesion to BRCA carriers and looked at the use of MR in these patients. And you can see the BRCA patients are the standard, and really those with personal history and even atypia had equivalent. There's no change. These p-values are too large. It's basically equivalent in cancer detection and PPV to those with BRCA mutation. So useful in women with a personal history. So what we reiterated again is that women with a personal history and dense breast tissue, we flat out recommend annual MRI starting at age of diagnosis. Anyone diagnosed prior to age 50, annual MR starting at diagnosis. Any others with personal history, consider MRI starting at diagnosis, especially if there's other risk factors. And personally, I would like this to just be flat out, everybody with a personal history should be screened annually with MRI. We just didn't have enough data in the evidence set to go full out on that, but that's really the direction I hope to go. All right, what about atypia? There's really not enough data. SIPO's study was a good start. Same for Black women as a separate risk category. We just don't have them separated out in studies so that we can look at this and make a recommendation. Dense tissue, though, that's coming around. We're getting more and more data. So we have the DENSE trial from Netherlands, which I'll talk about, and the EA 1141, which is Chris Comstock's trial, which I'm sure will talk to you about. So the DENSE trial was interesting. It's women that have just DENSE on their mammogram, no other risk, And they looked at interval cancers because that's a very good surrogate for mortality benefit. And this is interesting. So the interval cancer rate, remember, this is a randomized trial. So this is invitation to have an MR. Of the women who were invited, only 59% had an MR. But if you just get invited, your interval cancer rate gets cut in half, 5 to 2. It's highly significant. Now, the authors of this paper wanted to publish those who actually had an MR. And if you look at the abstract, it's not in there because they were not allowed to put it in the abstract. They ended up negotiating and getting it in the paper, but it just shows you the bias in the literature against this type of data. And I talked to the authors directly, personally, about this, so I know it to be true. But if you look at this, actually having an MR drops the interval cancer rate under 1. And the women in the invitation group that's reported in the abstract as MR group, those who didn't have the MR, it was 4.9, the same as having a mammogram only, because that's what they had, basically, a mammogram only, right? So these randomized trials, you have to be really careful about how you look at the data. All right, in the second round, which they've published in follow-up, you could see the incremental cancer rate remained high, tumor stage was low, and they had a marked reduction in false positives because now you had a comparison, right? So it's very good. And then finally, the abbreviated MR versus DBT. This is Chris's study. Like I said, I'm sure he'll go into this in more detail, but you can see the invasive cancers detected much higher with abbreviated MR than DBT, which is our best shot with mammo, right? And the sensitivity, look at the difference, 39 versus almost 96%. Kind of speaks for itself, doesn't it? So the cancer detection rate for MR in the EA 1141, 11 versus just under 5, so it's more than twice using MR. So for dense breasts, this was a very tricky recommendation to make because obviously MR is useful in these patients, but there's a lot of women with dense breasts. So what we said was the current recommendation is that if a woman desires supplemental screening and has dense tissue, she should have annual MRI. The alternative is contrast-enhanced mammography or ultrasound, but that's what we've recommended. Okay, so let's go ahead and summarize what the new recommendations say. And this is for 2023. For most women of higher than average risk, the supplemental screening method of choice is MRI. Just flat out. That's the way to do it. You want to find cancers early, that's what you do. You know, there's going to be more data on CEM. We did not have enough different studies on CEM, but that I think will accumulate over the next few years. That's an alternative as well as ultrasound. For genetic risk and untested first-degree relatives, those with a calculated lifetime risk of 20% or more, or chest radiation before the age of 30, we recommend annual MRI starting at either 25 to 30. So there's a range there because some of the mutations, like Li-Fraumeni, the women tend to have younger tumors at younger ages in BRCA1s. So it's a range between 25 and 30, and we talked about, like for RT, it's 25 or 8 years after completion of treatment. All right, what about those with a personal history of breast cancer? If they have dense breasts and a personal history, or if they're diagnosed before age 50, annual MRI starting at the age of diagnosis. Personal history not included in the above or atypia, consider annual MRI, especially if there's other risk factors. So I have a good friend, it's a black woman, she had a biopsy, she has dense breasts, she had a biopsy, it was LCIS. She called me, what should I do? It's like, you need an MRI and you need an MRI every year. So it's a fairly, I think, simple algorithm. For dense breast tissue, if supplemental screening is desired, MRI is the way to do it. So that's what's recommended. And that's all I have. Thank you very much.